So it's the level of impairment that makes a difference. C2 Asia D looks a lot different than a C2 Asia A. C2 Asia A is dead, right? Versus a D, you're gonna get them walking probably in like a week. So big difference. So that's what this test is designed for, to show prognosis on what is possible with this patient. Now again, it also gives us communication tool. It gives more information on what can you use your letter of medical necessity for any type of wheelchair, specialty wheelchair you'll have to get them. Sensory component, motor component, and then a completeness component as well. So first, I do light touch on the right, then I do light touch on the left, then I do pinprick on the right, pinprick on the left, and then I do my motor testing. 99% of the time, you are going to know the neurologic level of injury without even doing your motor testing. It's because sensory testing is more specific. How many more dermatomes do you have than the myotomes that you just checked? A ton more. And so therefore, you're going to get a bit more specific with your dermatomal changes comparatively to your myotomal changes or your score. So you pick anyone on the face, they close their eyes, and again you say, this is normal. So this is what you're gonna grade from here on out. This is your litmus or your barometer test. And then we're just gonna go through each of the dermatomes. You are going to tell them what you want them to tell you. So as I go through each point, my words that I like to use is I want them to tell me normal, not normal, or I want them to tell me if they don't feel anything. Because sometimes you just like wait there. And if they're not feeling anything, they don't know that you have touched them. And then it's like you're just staring at each other. So and I tell them, if you don't feel something within 5 seconds, I want you to tell me you don't feel anything. I promise you, I'm gonna touch you at each individual point. Normal, not normal, or I don't feel anything. Some people like same, different, or I don't feel anything. Use whatever words you want you to have the patient tell you, whatever words you want to hear. Because again, I'm trying to distinguish, is it normal versus not? If it's normal, you get a 2. It's not normal, which again is coming from their face, they get a 1. And then if they don't feel anything, they get a 0. As soon as you get your first 1, you're kind of done. Because that's your neurologic level of injury, at least for that side. But you have to keep going because it's zonal partial preservation. Because you're going to have to document whatever the ZPP is. Is it going to change much what we do with the patient? Not really. But we still document it. So, again, patient closes their eyes, and then I say that's normal. So, relax your eyes. If you look on the Asia sheet, they have a few points of interest where, again, what's the difference between a dermatome and a peripheral nerve? The dermatome is going to be significantly less discrete, so it's large. If I have a dermatomal issue and I tell the patient to, again, mark it, which you learned in history and systems, it's going to be really big. Compared to a peripheral nerve is very specific. So that means that within the dermatome, let's just say, again, C5, dermatome, I could clock here, I could clock here, I could clock here, whatever it is, just within that dermatomal space. But on Asia, there is a dot that says, most likely, this is where you're gonna get the best result on the most cutaneous sensory neurons coming in. Just like you have with reflexes and with myotomes, right? You can do C5 this way, you can do C5 this way. For several of your DTRs, it's several different levels, but some have a larger influence than others. Dermatome the same way. So, go through it. So this is, again, what normal is. Okay, so then we have C2. Now, the majority of individuals are going to have a collar on. Miami J, Aspen collar, could be a CTLSO, could be anything. So in the Asia exam, you take it off because you're gonna have to access part of where the collar is going to be impeding. They're not moving, so you're not going to break any precautions. So C2, my point of C2 is right where their carotid artery would live. That's where you're going to get the best chance of looking at C2. We won't go through every one yet, so we know that. C3 is going to be superior to the clavicle. C4 is going to be at the AC joint. C5 is going to be at the lateral elbow. C6 is the thumb. C7, little finger. C8, little finger. T1, medial elbow. T2 is going to be now at the anterior portion of the axilla. It is now where we have to start using our surface anatomy and our idea of surface anatomy. Which brings me to a logistical point. Your patient, logistically speaking, you want to do this test whenever they're like in a hospital gown. Because you're going to have to access, again, their skin. So in the ASIA exam is performed at least by a therapeutic individual, a PT, an OT, a PM&R physician in inpatient rehab. So therefore, you're dealing with a multi or interdisciplinary team. PT, OT, maybe speech, respiratory, dietitian, neuropsychologist, counselor. I want to be the first person to see this patient because I don't want the OT to get them dressed. I don't want nursing staff to get them dressed. So logistically, if I'm going to do an ASIA exam on a Tuesday, Monday evening before I leave, I'm going to go to that OT that has that patient say, look, schedule after me. I need to do the ASIA exam. I'm going to go to the nursing station and say, hey, this patient, don't dress them in the morning. I need them only in a hospital gown. Because what I don't want to do, this test is already going to take me, if you clock through this fast, best case scenario, you're done with it in like 45 minutes to an hour. First few times you do it, it'll take you 90 minutes easily. Just because, I mean, you're doing a lot of stuff. Then you're explaining it. What you don't want to do is roll in and the patient's completely dressed. Then you got to undress them. It's better for a schedule. So, once you get to T3, we think about our surface anatomy. We know T4 is nipple line. We know T10 is going to be at the belly button. So therefore, I know that I have to hit T3 just above that. That means T5 is going to be right below. Here's a rule of thumb. The rule of thumb is that each dermatome segment within the thoracic cord is this distance. It's about an inch. So if you just go down an inch, each individual one, you're going to hit the next dermatome. Now, dermatomes, they go around, which means, let's just say, T10, so T9, let's say T8 right here. I could check T8 here. I could check T8 here. They go around. But for consistency's sake, I will stay just 1 inch of midline. So I will go all the way down on the right, all the way down on the left, just for consistency's sake. And again, the more anterior you are, the less curvature you have. So you know that you're probably more specific. So in T3, T4, T5, 6, 7, 8, 9, we would land on 10 right at the belly button. Again, it's about an inch. And again, what are my verbal cues? I don't have any verbal cues. She's telling me everything. So again, I'm at T8. She says, normal. Now, for any reason, if they start telling you words that you didn't tell them before, or if you notice hesitation, I'll stop there and I'll go back to the face. I'll say, remember, this is what normal feels like. Grade it to this. Because they want to do really well. But you could also be encroaching on areas that have inaccurate sensory information secondary to their spinal cord injury. So that's where you educate them again, saying, look, there's no point in lying right now. I need you to be as accurate as possible because this is going to tell me your injury level and then also what you're going to be able to do once you leave this building. So accuracy and the truth is important. Okay, so then we have T11 and 12. I know that I need to, within here the inguinal ligament and within the belly button, I need to get between, again, T11 and then T12. Then we have lower extremity. So with lower extremity, we're going to have 3 on the thigh. So we have L1, L2, L3. Again, it's within this tangential curvature. So if you break up the thigh in 3 pieces, superior, middle, inferior, and we're moving more and more lateral or medial every single time. L1, 2, 3. And we have 3 on the foot very, very quickly. We have medial, we have anterior, and then we have lateral. So 1, 2, 3. L4 is going to be on the posterior aspect of the medial malleolus. It's essentially where you would feel very similar to like the posterior tibialis artery. L4. L5 is going to be anywhere in between the first and second webbing of the toes. And then S1 is going to be your just posterior to your lateral malleolus. Then we're going to lift the leg up. Now, here's always a question. I'm lifting the leg up and I'm on S2. S2 is going to be at the popliteal fossa. But am I not holding right here? Is this going to throw her off? Yes and no. It depends on how I hold her leg. Because again, I'm just trying to establish light touch. So what I'm actually going to do is I'm going to squeeze her leg even harder. Probably she's not going to feel it. But the reason I'm squeezing is because I'm trying to differentiate between just light touch and this very crude touch. Now, crude touch is the atriolateral spinal thalamic tract. I'm looking at the dorsal column medial meniscus. I'm looking at 2 different tracts now. So squeeze a little bit harder if you have to. If you don't want to do that, I mean, you could like externally rotate, but that's just typically what I do. I'm going to squeeze and give it a little bit of a push. S2, S3 now is at the hamstrings, and then 4, 5, you know. So we would do that on the right, and then we would do that exact same thing on the left. Then we have sharp and dull. So sharp and dull, anterolateral spinal thalamic system, it's going to try to mimic pain. Can I elicit pain? And then therefore, can I elicit no pain? And can she now discriminate between the two? So, same litmus test. I'm still at the forehead, but now my cues are very different. I don't want to hear normal, not normal, because that's not discriminating between 2 different things. So here, whenever we go through this, you do both. So that's sharp, and I tell her that's sharp, this is dull, just like that. So now I say every single spot that we just went through, I'm going to do sharp and dull, and you have to tell me which one it is. So it's not yes, no, normal, not normal, impaired, it's just sharp, dull. That's what I want to hear. So therefore, you're doubling now the amount of dermatomal places that you have to touch because you have to do sharp and dull. You don't have to do sharp, dull, sharp, dull, sharp, dull every time. You can mix it up if you want to. You have to discriminate. Few errors that can happen. If for any reason that, and like this would be a big error on Mary, she's thin. If I do dull on a bony prominence, a lot of times it's going to feel sharp. So therefore you want to try to get to tissue as much as you can. So areas where that could potentially be a problem, make sure you don't hit the clavicle, make sure you stay off the AC joint. Those are the 2 main areas that we might see potential issues in. So again, she has to tell me sharp versus dull on, again, what that is. Same thing. dermatomally on the trunk. Another logistical or user error that you might do is on the sharp, if you don't press hard enough, it might feel dull to your patient. Now there's no way to objectify, I'm pushing down with this many newtons per square centimeter and the amount of force of sharp versus dull. And so, therefore, you want to try to see an indentation in the patient's skin. So, like for instance, if we're just looking here, I'm going to push in to where I see an indentation. In fact, you're going to see it mostly on the trunk. Whenever you're done with the trunk and you're doing sharp on the trunk, you're going to see individual red marks. You're not creating a wound, you're not breaking the skin, but you're making an indentation to where you're going to push harder than you think you should. You're going to make a red mark onto your patient, because if you don't, again, if you're just, a lot of times that can feel dull very quickly. Especially in someone who you know is going to have impaired sensation. Absolutely. So, sharp dull through every single dermatome. So if we just started, C5 here. So she'd be closing her eyes. I'm depressing for sharp, and I'm depressing for dull. She would say sharp dull. Scoring wise. Sorry.
Yeah. It's a good toss.
So,
That's crazy.
scoring wise, I do sharp, she says sharp. I do dull, she says dull, she gets a 2. I do sharp, she says dull. I do dull, she says sharp, she gets a 1. I do sharp, she says dull. I do dull, she says dull, she gets a 1. I do sharp, she says nothing. I do dull, she says nothing, 0. Either way, 1 and 2, your neurological level of injury is set. It's whatever's going to be your most caudal, normal finding. 2's all the way across. Light touch, sharp dull, right versus left. So that's how the scoring system differs.
So if they get them both flipped, it's still a 1.
If they get them both flipped, it's still a 1. It's because it's not absent, it's just impaired, which would give you a score of a 1. The only difference that's going to make is going to be zone of partial preservation, or the potential of. And then myotomal testing. So myotomal testing, again, we can go through different myotomes, C5, all the way down through S1. So C5, and again, we would do it bilaterally. This takes 5 minutes, very, very quick. We're going to start against gravity first, because you want to try to give them more credit than they can typically have. So, bicep flexion, stabilizing, not a break test, no pluses and minuses, it's 0, 1, 2, 3, 4, 5. Start anti-gravity first. So, again, can you bend your elbows up? Great, she can. Apply resistance. If not, then we have to go to 0, 1, 2 scoring, which is gravity eliminated or minimized. Same thing. If she's able to go through the range, we clock her at a 2. If we just have a palpation with no movement, we clock her at a 1. That point. Now, the question came up in lab, well, what happens if they just go through half the range in a gravity minimized position? You would normally give them this minus, correct? There's no minuses. So we round up. We give them a 2, because that's more than a trace. And 1, in a long time, but I don't think there's pluses and minuses in 1s. 1 is just defined as a trace. So it's more than a 1, got to be a 2, therefore. You round up. You give them credit. Wrist extension. Again, patient goes up, gravity against gravity. Apply resistance for a 4 and 5, whereas gravity minimized, same thing for a 0, 1, or 2. Triceps, this position here, I am guarding so that if she is able to extend and she cannot eccentrically control it, she doesn't pop herself there. Again, This is for 3, 4, and 5 versus 0, 1, and 2 extension. C8 is going to be distal DIP flexion. This is where you're going to see a really big compensation. If the patient, if you're looking to clock them at a C8 and C6 is already intact, they might go into wrist extension to get what looks like active finger flexion, when in reality it's not. It's a tenodesis grip. So therefore, I'm going to lock her down. And I have my fingers underneath her wrist and the back of her hand. If I then see that as she's trying to flex her fingers, if she lifts out of my hand, then I know that she's using the compensation. So then I will automatically bring her to gravity eliminated, to where she will just curl there. And then T1, finger abduction there. Against gravity, gravity eliminated, it's such a weak muscle. And so splay the fingers just like that, and I'm just looking at what type of, again, not strength of a muscle contraction, is it present at this point. Lower extremities, so we have L2. So this is not ideal, again, for against gravity. Against gravity positions, you're going to be supine, hip in a neutrally rotated position. Not perfect for against gravity, but it's what we got. So all I'm going to ask her to do is go ahead and bend your hip, bend your knee, try to bring your knee all the way up. Very good. So that would be a 3. And then we apply resistance for 4 and 5. If we cannot have this active movement, then we're going to externally rotate, which gravity pulls this way, movement is this way. So we're in different planes. So now, same thing. Go ahead and bend up, and then I'm palpating again for a contraction if I need to for a 1. L3, it's just going to be a short arc quad. Here versus here for a 0, a 1, and a 2. Same position. Can they straighten out their knee versus a 3, a 4, and 5? Can they extend it, again, against resistance or not? So L2, L3, L4, dorsiflexion, same thing. 3, 4, 5 versus 0, 1, and 2. Great toe extension. This would be 3, 4, 5. 0, 1, 2. Same thing. Plantar flexion is where it gets different. S1. So the leg is up in this position. In order to go to get the score of a 3, so the patient is going to, at this point, can they just bring their heel up off the mat? So that means, can we go against gravity? That's one way to do it. You can also put your hand underneath as well. You can stabilize the toes, and then can they lift off of my hand? Can they lift off just like that? 0, 1, and 2, externally rotated. Or can they go into this plantar flex position? And then 4 and 5 is where they're going to push into my hand like a gas pedal. So S1 has 3 different positions. To score a 3, it's the odd position. This is the only position, because you can't use 4 and 5 here. What some people want to do is, go ahead and just lift and then like try to push down like this. That's more of an approximation this way than it is pressure this way against the gastrocs. 3, 0, 2, 1, 4, 5. That's Asia exam. Motor-wise. Okay, so then S4, S5, to where we have subjective, we have objective. And my vernacular to the patient is this last part. So far, I've looked at sensation, I've looked at motor, right and left. This last part is going to tell me if you have a complete injury or an incomplete injury. And before I even tell them what the test is, I say we can do it one of 2 ways. I can do it subjectively, where I will ask you 2 questions. Or I can do it objectively, where I'm going to get a little invasive. Yeah, I haven't told them what it is. But I say, here's the difference. Subjectively, I have to trust that what your body is telling you is what you're telling me. Remember, you have altered sensation and motor action. To what extent, I don't know yet, because of a spinal cord injury. So you might think you're giving me an accurate answer, but in reality, your body's lying to you, and you just don't realize it. What I'll go further from there is, here's the reason why I prefer to do it objectively. It's because we're going to get a definitive answer. And if I can do this objectively, I can tell you right now, here and now, I can tell you if there's a probability if we're going to be able to walk or not. Maybe not during inpatient rehab, but if it's a possibility later on down the line. Again, I'm not using the words definitively. I'm not speaking in absolutes. I'm just saying if there's a probability. Because this is going to tell me if you have a complete injury or an incomplete injury. Because you already know your neurologic level of injury. At this point, you know what it is. That's why your level of impairment is so important. Because if we're clocking Mary at her neurological level of injury at T1, I really need to know what the impairment scale is. Because T1, incomplete, we might be able to walk. It's going to be very arduous, but we're going to use a lot of different hip CAFOs. We're going to be able to use the exoskeleton. We're going to be able to do a lot of stuff. It's going to be very arduous, but we have the potential. But if we're T1 complete, Asia A, then we're thinking probably not. Whereas T1, C, or D, well, shoot, yeah, we can walk right now. And so again, I need to know that impairment scale. And so I tell them the objective way tells me that right here, right now, today. And that typically sways the patient because by now they want to know answers. They want to know what tomorrow looks like. They want to know what 10 years from now looks like. And again, this is how we're going to look at completeness and incompleteness. And you describe the test to them of what that's going to entail. Obviously, in this situation, I would bring in a female with me, not a family member female, but a female staff member. I don't care, again, if it's the dietitian who has nothing to do with this. The dietitian's coming in with me. If it's, again, male on male, I don't care, whatever. If you're a female therapist and I'm your patient, you're going to bring in a male therapist with you. It's not going to be a female. Again, I'm speaking, that's what I recommend. That is just what I think is best. Subjectively, if your patient says, I'm good, we're just going to answer some questions. Then you ask them 2 questions. Again, we're looking at deep anal pressure, voluntary anal contraction. For deep anal pressure, you ask the question, can you feel when you have to have a bowel movement? Sensation. If they say, oh yeah, absolutely. Worst case scenario, they're a B, based off of what they're telling you. Worst case scenario, they're a B. Then you say, for voluntary anal contraction, can you control a bowel movement? If you can feel it like you say you can you control it? And if they say, oh yeah, absolutely, they're at worst a C. It then all has to do with your myotomes that you checked out. If they say, no, I cannot control it, I've had 3 accidents today, then they're probably a B, most likely. Probably a B. So again, it's looking at, are we complete, sensory incomplete, or motor incomplete, A, B, C, D, when it comes down to impairment scale. If they do it objectively, patient rolls onto their left side, you will hip flex the right and left leg, and then you will insert up until your DIP first digit into their rectum. When that originally happens, you are going to feel a contraction. That's an involuntary contraction. I will then ask the patient, do you feel my finger? They say yes, then we have, worst case scenario, we got a B. I say, okay, great. Now I want you to contract around my finger. stop a bowel movement, pinch one, whatever. Read the room, whoever your patient is in front of you, right? If it's a 17-year-old boy, anything goes. So again, say whatever you want to say to get them to contract. If you feel a contraction, worst case, we got a C. Might be a D. Again, based off of their myotomal assessment. Over half the muscles have a 3 or better, it's a D. Over half the muscles have a 3 or less, we got a C. If, again, voluntary anal contraction was in time. Cool?
Cool.
That's Asia.
Thank you.
I have a
Thank
question. How would you prefer us to